Hello, and welcome to another edition of the Business and Experts Forum. For those of you joining us for the very first time, I just want to welcome you to this wonderful program. This is a platform for developing people and businesses through knowledge sharing. All we do here is to share knowledge with people. It is free knowledge sharing. We bring in the experts and they tell you about their expertise and their area of specialization. We bring in business executives, people who are in budding businesses, and also prospective entrepreneurs. And also, we use the opportunity to highlight the progress that are made by these people, and they are all people who are willing to go the extra mile to achieve things to improve their lifestyles. And we do that by discussing some of the strategies that they have adopted. The forum also features specialists and experts in their respective fields coming to share knowledge on everyday topical issues such as technology, finance, medicine, engineering, entertainment, social media, the law, just you name it, we've got it. So if you're someone who wants to go into business to improve your business processes or to gain knowledge, or if you want to develop your passion and talent into a business venture, then this forum is for you. And we are live every 2 weeks on Monday at 7 p.m. British Summer Time. Please remember to subscribe to our channel and click on the bell so that when there is any new episode, you'll get notification. Right, tonight we have with us Dr. Mrs. Abner Osella, who is a consultant clinical neurophysiologist and who has made tremendous contribution to research in motor neuron disease. She has been practicing medicine for 27 years and has a professional aspiration of training and mentoring future neurologists and neurophysiologists. Dr. Mrs. Abner Osella is here tonight as an expert in the field of medicine, specifically dealing with the brain, muscle, and nerves, and is going to help us understand some of the health challenges associated with muscles and nerves, as well as general health and well-being. Ladies and gentlemen, please welcome Dr. Mrs. Abner Osella.
Thank you very much, Marcus. I'm very happy to be here.
Abner, you're welcome, and it's nice to have you here. And I'm pretty sure that our audience will have loads of questions for you. I have some questions for you as well, and we'll do as much as possible to go through the questions as quickly as possible. So let's start go straight to the point. I'm going to read to you something that I read from a website, and it's specifically what they call Epilepsy Research UK. It says that clinical neurophysiologists are doctors who investigate and diagnose disorders of the nervous system, such as neuromuscular disease, nerve entrapment, epilepsy, and ophthalmic disease. So, can you explain in a layman's language what that means for you as a neurophysiologist?
Yes, certainly. So the clue actually is in the name. When you hear the neuro, it's telling you that we are somehow involved in uh, neurological diseases. So I thought just a brief recap of maybe O-level biology. I've got my props here.
Okay,
So that's the brain.
okay,
So this is the nervous system, involves the brain, which you
okay,
can see with the different parts. And I've also got a spine here with a spinal cord inside the spine.
okay.
Okay,
Really
so the
interesting.
nervous system involves the brain, the spinal cord, which comes down into the spine. And if you can see in this model, you've got little bits coming out of the spinal cord. So these
Yes.
are the nerves. So the nerves in our arms, in our legs, they actually start out in the spinal cord and travel down to our limbs and every part of our body, really, to our gut, to our heart, to the neck, to the skin, to our bowels. So problems in the nervous system can show up anywhere. So sometimes it's very rare, but sometimes a problem that may start, it might sound like it's a problem in the heart. It actually could be because of the nerves that supply the heart. That is very rare, but it does happen. So what I am involved in as a neurophysiologist is, I mean, the patient sees the doctor. The patient will say, well, I have this symptom or that symptom, and the doctor tries to make a diagnosis. Much of medicine is about making a diagnosis in the patient. So sometimes the doctor doesn't need a test. What you say and the examination will straight away tell the doctor what you have. Other times it's about having a list of possibilities. So your doctor will listen and then at the end say, well, I think these could be 3 or 4 things. Let's confirm some of them, let's exclude some of them. And sometimes tests are needed for that. So my involvement is in testing patients who may turn out to have problems with their brain, their nerves, their muscles, and then saying, well, I think this is a problem in the brain. Maybe it's in the front half of the brain, it's in the back of the brain, it's actually in the spinal cord, in your neck. So that's tingling you're having in your hand. It's actually not a problem in the hand or arm itself, but the problem is actually in the neck. So we call it localizing. So we help to localize where the problem is. And that is goes a long way towards helping the doctor to make the diagnosis of a neurological problem.
Okay, okay,
Yeah.
that's really interesting. It's interesting that you sorry, were you done?
Yeah, I'm done for now. Yeah.
Okay, okay. So it's interesting that you mentioned O-level biology. I see that someone has put in the comments O-level biology with a laughing face to say, "Well, how wow, we can't remember anything we did in O-level." So you deal, as you mentioned, you deal with brain disorders, which sometimes shows itself in the form of seizures or
Yeah.
epilepsy, as we normally call it, and fits. Can you tell us what the difference is between the two? What are the differences
Yeah.
between seizures and fits?
So I think I'd say a fit is probably the layman's term for a seizure.
Okay.
Now, not everybody who has a seizure has epilepsy. So somebody might be drinking, might have had a lot to drink alcohol, and then suddenly stop drinking. The person might have a seizure. It doesn't mean that person has epilepsy. There's a reason that person has had a fit. That sort of person, you're not going to give them the drugs for seizures. The problem was the alcohol withdrawal. So you're going to try and manage the alcohol and help him to withdraw safely and hopefully ultimately lead him to control his alcohol drinking. So not every seizure means you have epilepsy. So epilepsy actually refers to somebody or a condition in which you're having recurrent seizures. So that is where we would put the label epilepsy. So obviously this is one of the challenges. Sometimes patients don't understand. They've had a seizure, they've gone to see the doctor, nobody's doubting it's a seizure, but based on that one seizure, sometimes it's not very wise to label the person as epilepsy unless there are other risk factors for epilepsy. So that is sort of I'd say that's the sort of difference to a seizure. Epileptic seizures are a type of seizure, but if you've had only one seizure, unless there are other risk factors, we wouldn't necessarily say you have epilepsy. We'd wait for other evidence
Okay.
before coming to the conclusion that this person has epilepsy. And I mean, there are different types of seizures. I mean, when you talk about fits, about seizures, people are often thinking about where the person falls to the ground, screams, shakes, very dramatic.
Mm-hmm.
And yes, those are generalized seizures. They can be very dangerous. Patients can die if that sort of thing isn't managed. But there are other sorts of seizures. So, there are seizures where the patient hardly does anything. You might sit next to somebody on the tube who's having a seizure and you won't know that the person was having a seizure. So, but obviously you can imagine if a child is sitting in a classroom having lots of seizures, the child is missing, child is missing a lot of the education. So sometimes the signs are very, very subtle. And that's where, a teacher might notice something like, the child might stop very, a common scenario we would have is a patient who's been sent to us because several times in a day for a few seconds, a child, usually between 4 and 8 years old, will stop, will stare. Parents will say maybe fiddling, and sometimes the teachers are the ones who will notice. And then you think, well, are these seizures? Are they not? So one of the things we'll do a test called an EEG. I work with my technical colleagues, and they will stick electrodes on the child's head and record. Usually the standard would be about 30 minutes. And we know the hyperventilation, so getting the child to breathe in a certain way can sometimes trigger these seizures. Our goal is always, if possible, to try and record the episode that the child is reporting, or the parents have noticed, or the patient is reporting. Because if you can capture the episode, you've got it on video. We have a video as well, so capture the episode on video, and also get the tracings from the brain, see what the brain is doing while the child is having that episode. We can use that information to say yes. So within 30 minutes, we can tell the patient, the doctor, this is an absent seizure, and that's going to guide the referring doctor to what sort of medication may be right. We'll give advice on, swimming, because obviously if a child is having lots of seizures, subtle seizures. So the big seizure everybody knows, but the subtle seizures, it can be very dangerous. You're swimming in a pool, suddenly have a blank spell. Nobody knows you're having seizures. It could be quite dangerous. So part of our role is in educating the patient, especially when they're newly diagnosed. They come and see us. They're not on any medication. We try and we make the diagnosis. So that's a simple one, come in for 30 minutes or so. But sometimes we're recording for days. So a patient might come in 4 or 5 days, recording continuously in hospital with a video on, EEG electrodes on, recording the brain activity while the patient's in hospital, with the aim, hopefully, that the patient will have one of their episodes. There are things we can do to trigger an episode if necessary. Sometimes now, what's the more modern thing is we can actually send the patient home with the kit. We have ambulatory equipment, which patients just love. They don't have to sit in a hospital bed. We stick it on, they go home in their own environment. They are likely to have their episode. They come back after 3 days or so. We download the data, and then we can look at the video, look at the tracings. We'll confirm with mom, or because as you can imagine, somebody who has a seizure, actually they are not the best person to get information from. It's usually
Right.
the
Right.
witness, the parent,
That's
the
correct.
sibling, the spouse, who will tell, is this the episode you're worried about? And they'll say
Yes.
yes, and we'll say this is a seizure. Or sometimes they are not seizures. Sometimes they can mimic seizures, and they are not seizures. So we see patients who've had medication for seizures for years. And then
Okay.
when they come in, eventually you record the episode. Say, is this really the episode you have? Say, yes. Do you have any other kind of episode? Because again, people can have 2 or 3 different types. So say,
Okay.
this is the only episode. And you realize actually all this time the patient has had medication. It is not, and it's not a seizure. So obviously anti-seizure medication is not going to help, and the patient may have other treatments. So medicine, very, very much about diagnosis. If you can make the diagnosis, then you have treatment options. You can counsel the patient. You can give them a prognosis. If you haven't got the diagnosis, and there are many things we struggle to put a label on. Where we haven't put a label on it, it becomes a lot easier to talk to patients, and patients get very frustrated about it. But in a nutshell, so that's where my EEG or epilepsy work, that's what I
Okay.
do, helping to. And well, I forgot to say, some people too, they have epilepsy seizures that can be treated with surgery. So
Okay.
that's, we might record and say, okay, this is coming from this side of the brain. And
Brain.
obviously it's a big decision. If you're going to take out some of somebody's brain, you have to make sure it's not a part of the brain that is very useful, some other aspects of life. So there's a lot of and those are, sometimes we'll have to actually take the skull. The surgeons will remove the skull. We'll have to put our electrodes on the brain itself. When
Right.
we're getting into really detailed work, when it becomes a surgical procedure, then that's a lot more involving, and we may
Okay.
have to test the patient several times, come and go several times until we're sure. Yeah.
Very interesting, and really really technical, I must say. Really really technical. Now, I was reading that there are over 40 different types of seizures, and seizures are different for each individual, and
Yeah.
that can be really really interesting, or very disturbing for parents. And it's interesting that you also mentioned to do with children, because I was going to ask you that if how can I convince my doctor that my child has had a fetal seizure when I visit the doctor in the hospital, because at the time that probably the time that I visit the doctor, that child is not having any episode, to use your word, your term,
Yeah.
episode. So it's going to be difficult to convince the doctor that my child has been having the seizure. But what you've done, what you said is, they can then carry out a test, and they can actually trigger the episodes,
No, we
and then
can't trigger. No, we can't trigger every type of seizure. Some
okay,
seizures we know there are definite things that will trigger them. So, yeah, but that is a problem with seizures. You go and see your doctor, it's not happening.
right,
What a lot of, especially with parents, a lot of parents are, and we really appreciate it, they're taking the video. It can be very distressing when your child is having an episode, but if you can calm yourself down, especially obviously the first time you're not expecting it at all, so it's probably difficult to get your phone out to record. But
Right.
after it's happened a few times, just tell yourself next time it happens, I'm going to get my mobile phone out, record the episode. And I mean, I have actually advised a friend. This really happened. They were, especially if the person, your doctor is not somebody who's has had any training in epilepsy, it can be very difficult to, to get them to think. And as Marcus has said, seizures can come in so many different forms. Somebody's seizure is just they get this feeling in their tummy, like a feeling of fear. And for that person, it's just so they might have the episode of fear many times. They don't like it. They can't convince anybody it's a seizure, and then they go on and have a big seizure. And then in retrospect, oh, okay, so that thing you had there, that was the start of
That was it.
your seizure. So seizures can be many different types. And yeah, so what we found that in fact in our department we have a whole folder for parental videos. They are so
Right.
useful. So the patient brings to say, so sometimes even if the patient's in hospital, we try all our recordings, we can't get the patient to have a seizure in hospital or with all our fancy equipment. Sometimes just looking at what the parent has recorded, you say, yes, there's a high probability, and I will include it in my report. I'll say, yes, we did 5 days. Unfortunately, we didn't capture an episode, but we've had a look at the video. I've consulted with my colleagues, and we'd say, because of the way the patient's eyes were open, arm moved, whatever, or the patient was motionless, all these things are highly suggestive of a seizure. And so sometimes the doctors will move and start the treatments with that.
Okay.
So yeah, but many different types of seizures, and there are many
Right.
things so that can mimic seizures, but they are not seizures. We've had people who have been thought to be possibly having seizures. They've been on anti-seizure medication. They come in, and we notice when they have the episode. Sometimes, and you see that it's actually because when we are recording from the head, we record the ECG, the cardiac as well, and actually the patient has the heart stops for several seconds. So those blank spells or those floppy episodes like that the patient is having, they weren't actually epileptic, but they're actually cardiac. So we've had sometimes on a Friday after you see this thing, you can't let the patient go home for the weekend and then you're scrambling around trying to find somebody to pace. Because sometimes pacing, you have to pace, take over, or put in, get the cardiologist to see to make sure that this child or this person doesn't go home, have one of these 10-second episodes, and then the next thing you know, the person is dead. So, I mean, diagnosis is very important, and the EEG and the video has been a great help in the last few years. Combining the video and EEG technology has been absolutely amazing and adding a lot of information about the diagnosis of epilepsy.
That's really helpful because I mean I'm really happy about the point about recording the episodes because like you said it can be a case where you go to the doctor and that episode or that condition does not occur and you are trying to explain to the doctor what actually happened but you can't because
Yeah,
at the time that happens especially if you're a parent you are in a state already and it's going
yeah,
to be really difficult.
yeah.
Do fits and seizures affect specific communities?
Um, I think I would say no, not communities as no. I mean, there are risk factors for epilepsy. So, for example, children who are born with any brain damage, you can imagine it just puts you at such a high risk of having seizures, because what's happening with a seizure is a part of the brain is irritated. So the neurons, again, O-level biology, we got the neurons, they fire together a little more together than they should. And then, so you've got too much firing in from one part of the brain at a time, and then you have the seizure. So anybody with any sort of brain damage is a high risk of having a seizure. So that's usually in a child. In adults, somebody who's had a head injury, that's a risk of seizures. You've had a stroke. Stroke is another underlying risk factor for seizures, and increasingly we're even seeing seizures in people who have dementia. So generally anything that causes brain damage could put you at high risk of seizures, but I'd be very reluctant to say certain communities are more at risk. I suppose if you could think about communities where they intermarry, we know that when you intermarry you're more likely to have certain genetic disorders, and if
Right.
the brain is involved in some of these disorders, you could have a high incidence of this. But no particular community comes to mind as being exceptionally high risk of having seizures. Yeah.
Okay. So one other thing that I want to find out are there. I mean, I'm sure there are medications that you prescribe for people with who suffer for repeated cases of seizures and fits. The question is, are there any side effects to some of the medications that will be prescribed?
Yeah, absolutely. I don't think there's a single medication we give in medicine that doesn't, unfortunately, that doesn't cause side effects. Everything will have its side effects, and what I would say, and you can this is important in terms of any medication you take, hypertension, any of these chronic diseases. If you think that you're having side effects which are you really cannot tolerate, I
Mm-hmm.
mean, you go back to your doctor because there are other alternatives that can be tried. So sometimes it's a bit of toing and froing. We try this. The patient says, I can't handle this. It's making me drowsy throughout the day. Sometimes it may not be the drug itself. Maybe the dose has been increased because we usually start with a very low dose and go
Yeah.
up gradually. Sometimes, what is gradual for one person might be a bit too fast for the other.
Okay.
So, if there are any issues, it doesn't mean you can't take medication. Honestly, if you have a type of epilepsy where you need medication or your child needs medication, it is really, really, really very, very, it's not advisable at all. You do not stop anticonvulsants. That's what we call them, anticonvulsants. You don't stop them
Okay.
abruptly. That in itself could lead you to have more seizures. So if you think I'm having side effects, I'm finding them difficult to tolerate, you talk to the person who's prescribed them. It might be just a case of dropping the dose down a little bit
Right. Okay.
for a few more weeks and then turning it up again. It might be that, well, you really cannot tolerate this. We'll have to wean you off it. While we're weaning you off it, we start another drug and try you on that new drug. So,
Okay.
yeah, nothing in medicine is without side
Side
effects. I've
effects.
even seen neurological problems which have been caused by taking too much vitamins. So there you go.
Okay.
You can, so nothing, everything
That's
can have side effects in medicine.
in
Unfortunately, we haven't found the perfect drugs yet.
very, very interesting. Very interesting. Okay, I just want to say, please, if you have any questions for Dr. Abner Alcela, please put them in the chat. We try as much as possible to answer as many of the questions that come through. And also, I would just want to introduce at this point who our next guest is going to be. I know we have a lot of questions for Doctor, but just so you know, on the next episode of Business and Experts Forum, we're going to have Mrs. Ebukum Olajide. This is someone who is CEO of a company known as Chili Gold, and that is a unique business which transforms chili, the chili that we know, some of us call it pepper, into a variety of products for a wide range of markets. And she's also known for providing motivation for prospective entrepreneurs by helping them transform their passion into business profits. She'll also be sharing her story on being an outlier, the fact that she has actually is actually making a difference to her personal life and her business life by just being different. She's just doing something different, just pursuing a pathway that is changing the status quo. So please join us on the 13th of September to have some discussions about her strategies and some of the challenges on her journey. So let's go back straight to Abner. Um, Abner, the one thing I wanted to find out from you, are there things that are not safe to do if you are someone who experiences seizures? Is there things that you are mostly advised not to do?
Yeah, so there are things, like as I mentioned, swimming. It's ideally you should be supervised. Having baths, I think, well, I presume there are mostly Africans on the call. I don't know. Most Africans do not have, we prefer the shower to the bath.
Okay.
And when you have epilepsy, we advise that it's better you have a shower than a bath. You can imagine if somebody's lying in the bath full of water and you have a seizure, you drown. We've had some unfortunate cases. So that's the sort of thing. But as much as possible, current thinking is we empower the patients with epilepsy to live as normal a life as possible. So,
Okay.
a friend of mine called me. Daughter had been recently diagnosed, teenager, 15, 16 years, just diagnosed with seizures. And of course, she's worried. Can I let her go out with her friends? She's a 16-year-old. She wants to go sleep over.
Okay.
Absolutely. Just empower her. Let her know, with the sort of seizures that teenagers have, there's a type of epilepsy that teenagers can have. We know things like sleep deprivation, um, drinking alcohol, for example, can trigger those seizures. Let the child know that. And we have, if you're in the UK, most services will have an epilepsy specialist nurse, and they are excellent at liaising with the patients, educating them. So don't, as much as possible, don't try and mollycoddle them, because then that's just setting up problems for later. Empower
Okay.
them, let them know, yes, you can go. Of course, let the friends, her good friends, she's going to sleep over, know that if she has a seizure, in the unlikely event that she has a seizure, this is what needs to be done. But generally, once the patient has been started on medication, seizures have settled, we encourage a person to have as normal a life as possible. Just be
Okay.
mindful, and usually things like when you're traveling, you go transatlantic and you're sleep deprived, the time difference, it can cause a lot of chaos, even for those of us, you don't know where your sleep pattern is. And we know those are very tricky. It can be tricky for patients with epilepsy. So if you let your team, your nurse, the nurses are usually very, very approachable, even the doctors as well, but the nurses in particular,
Okay.
let them know I'm traveling. What are the sorts of things I need to be avoiding? And, just they will advise you about what to do about the time difference, just to make sure that you're not sleep deprived. And sometimes you need rescue medication. And there's some seizures that you can have breakthrough seizures quite easily. What to do if you have a breakthrough seizure? So I mean, we try not to stigmatize patients with epilepsy. We try to
Right.
let them live as normal a life as well. There's a lot of
Exactly.
stigma, especially I know in Ghana and Africa, lots of things. No, we try to, let them, empower them, let them make their choices, and then just let them be. And but things like have a shower, and would say keep the bathroom door unlocked,
Okay.
so that if something happens, somebody can come in and help you. And then there's some of the very, very disabled children who have such bad epilepsy. Unfortunately, they have to wear a helmet because they are falling all the time. So there are little things like that. But by and large, most people with epilepsy, we can encourage them, set them free, let them live the kind of life they want to live. Sometimes they will tell you they know what triggers their seizures, and they will come and tell you themselves. Yeah.
Okay. Right. So I'm just going to ask you one more question, and we can go to some of the questions that are coming in from our audience. Um, let's talk a little bit about epidural treatment for women.
Epidural.
Epidural treatment for women,
Yeah.
yes.
Okay.
Now, some have complained about effects such as numbness in the leg, after the treatment. What are the causes of these, and are these can this be related to, or can this be described as some fit of seizures?
So no, so really a seizure, even though the patient's limbs and arms and are affected, the seizures manifest in the arms, the legs, etc. Really, for something to be a seizure, the problem is in the brain.
Okay.
So with the epidural, and I presume you mean, for example, for cesarean section, for
For cesarean
labor,
sections,
yeah,
yes.
patients have a lot of epidural or spinal anesthesia for that.
Yes.
And I mean, the whole idea is you're giving the local anesthetic direct into your
Spine.
spine to numb the
Yes.
nerve so that the doctors can go ahead and do your cesarean section. Unfortunately, for some reason, some people can have nerve irritation so that they don't recover as they should. I mean, the vast majority of patients, they are okay after they've had the baby. Um, the numbness, the whole idea, the numbness disappears, you get your feeling. But of course, with medicine, as I've said before, everything we do, nothing is 100%. Occasionally, we have had patients who've had damage, either as a result of maybe the injection wasn't done properly, maybe the
Okay.
needle may have hit a nerve or something. So, but that's really very rare. I mean, sometimes the patients might be numb for a bit longer than you expect, but most people would recover. So, um, yeah, the numbness is expected. That is the aim of the local anesthetic. We want you to be numb so that your abdomen is numb. You can do the cesarean section, take the baby out, and most people recover. But occasionally there can be nerve damage as a result of that. Yeah,
Oh, okay. Okay.
but those
So
are not seizures. No,
those are
but the
not
seizure.
seizures.
So the problem is from the spine,
Okay.
but with the seizure, the problem has to be coming from the brain primarily. Yeah, it's a brain problem.
Okay. I know you said you have the brain prop there. So in terms of where exactly that electrical activity is triggered in the brain that causes the seizure? Is it any particular part of the brain, or could it be anywhere
Yeah,
in the
exactly. It
body?
can be any part of the brain. It can be any part of the brain. So I've got my model, my prop here. So this is the front of the brain.
Do you want to lift it up a little? Yeah, that's
Let's see.
to
Where
your
am I
left,
with
to
my
your left, to
video?
your left. Yeah, that's a up a little. Yeah, that's fine.
Yeah,
That's good.
okay. So
Yes.
this is these are the frontal lobes,
Right.
and some of the seizures we see are seizures arriving from the frontal lobe. They can be very very different. The patients. In fact, sometimes people think the patient has is having a mental health problem, is having a panic attack, or is just gone mad. Sometimes they
Right.
just think the patient can just wake up, just scream, looks very fearful, everybody's running away from them. They're actually having a seizure. And it's actually not that rare, and often their seizures are at night. So we see those. I think the common ones we see from
Mm-hmm.
the temporal lobe, this side here, maybe I'll show you, it's around here. And this is that's where they feel the fear in their tummy. You feel like something is rising up. So there are different types of seizures. You can have it from anywhere. You can have it deep, if I can separate my brain. You can have it, yeah, arising very deep.
Okay.
Yeah, very deep inside the brain. And then if you're thinking surgical options, that's a real issue. Not very easy to get deep into the brain without causing damage to something else. So really, to be honest, epilepsy can arise from any part of the brain. I don't want to go into too many details. Really, technically, we'd say it's the cortex. So it's a
Right.
surface. The problem is the surface of the brain. There are some types of seizures that come from the brain stem. They're a bit lower, slightly lower down, and But anyway, that's. I think I'm getting a bit technical. But generally, seizures can come from any part of the brain. So any scarring, any irritation in any part of the brain can trigger a seizure. So this is why the manifestations can be so different, because it depends on which part of the brain the seizure is coming from. If it's coming from the area of your memory, then it can give you funny things. It can make you see things like things you've seen before. It can do all sorts of things to your
Right.
memory. So in a sense, it's about somebody who's trained to hear the story and recognize that this story is describing seizures. Some of them
Right.
are so subtle, you really need an expert. The expert may not even need a test, just that trained ear to see. You've seen so many patients with different types of seizures. Just listening to the story, you get your gut feeling, tells this is likely a seizure. Let's send them to Abner for a test to
Okay.
try and confirm that. Yeah, but it can be any part of the brain.
Okay. That's really good. We got a few questions in the chat now. I'd like to try to bring in some of those questions. There's one that says that just wondering, when do you stop an epileptic patient from driving?
Yeah. Okay. So now I have to. This is why I have to say that this is. I practice in the UK. I know the laws for the UK. It might be different in other countries. I don't know where people might be tuning in from, but certainly in the UK, if you think a patient has seizures initially, the patient has to stop. It's not the doctor's responsibility to tell the DVLA that the doctor tells the patient. It's the patient's responsibility to inform the DVLA, this is it, I've been diagnosed with epilepsy, and the DVLA will look at the evidence and tell you what you have to do. So usually the first 6 months, usually they will typically in a straightforward case, you will stop driving. And
Right.
then if you've been seizure free for about 6 months or about a year, or if you can prove that your seizures only take place in sleep. So there are little caveats here and there. Then if you're so even though so when you're still on medication, you may still be on medication, but seizures have stopped. The seizure, so
Right.
everything is stable. Either that, or you can prove and you can convince the DVLA that all your seizures take place in sleep. Then it's possible they may give you back your license and let you drive. But
Right.
yeah, I mean, you can imagine if somebody has even the subtle seizures, a blank spell where 10 seconds, 15 seconds on the road, you're not actually there. You can imagine what a risk it is to everybody
Right.
else and for that patient himself. So first thing, as soon as you report it, if it's thought to be a seizure, then we will tell you you have to inform the DVLA, and we will write it in
Okay.
your notes that we've told you to inform the DVLA. But it's not our responsibility to inform the DVLA. It may be different in other countries.
Okay. Okay. So there's another one that says, how do you know when to stop medication for seizures?
Yeah, that's a very good question. So, so just, I mean, we've been talking about, so really, you want to, so first of all, I have to say it depends on the type of epilepsy you have. So this is where I may be sounding a bit technical, but there are some epilepsies, especially as I'll say, some that happens in the epilepsies that come on in the teenage years. Some of those have a very good prognosis. Within a few years, it all settles down and you can start to talk about coming off the medication. There are some epilepsies too that we know they have a very, very low risk of going away, of getting better. So this is why we put so much effort into trying to make the diagnosis. And the diagnosis is not just to say you have epilepsy. There are different types of epilepsy. So we will try to use the test I do, MRI scans, and lots of things. The people who witness your seizures tell us, and we will come to make a quite a, what we call a syndromic diagnosis. We try to narrow as much as possible the type of epilepsy you have. And as I said, medicine, if you have a diagnosis, then you're on to a good thing. Then we can look at the literature of all the people who have this sort of epilepsy. How many of them go into, we call it remission, when your seizures go away? How many of them go into remission? For how many of them does this remission last, even when you take off the medication?
Right.
So the patient will come and we say, right, I haven't had any seizures for 2 years or so. I think I'd like to try. So it's always for the trial of withdrawal, because that is what it is. You're trying. Sometimes as soon as you start, the patient starts to have seizures. Actually, and other patients, actually, they never want to come off their medication, because it's
Right.
like, okay, they've got their driving license back, they've got their independence.
Mm-hmm.
And you, the doctor, say, look, you've had no seizures for 2, 3, 4 years. Should we try taking off your medication? And they're so worried they might lose their license, because as soon as you have another seizure, that's it, your license is being
This is
removed.
gone.
So it's a bit of a discussion between patients and doctor. There is a risk, and you have to decide, the patient will decide how much of that risk is ready to take. And sometimes you have teenagers coming up to the age where they will start driving. They won't let you touch their medication. They
Yes.
want that independence. I want to be able to drive. So
Okay.
yeah, it's different scenarios. Depends on the type of epilepsy. Depends on what the patient wants. Some patients choose not to have a trial of withdrawal at all.
Okay. Okay. So if you've just joined us, just so you know, we have been talking to Dr. Mrs. Abner, who is um, neurophysiologist, clinical neurophysiologist, who's been talking to us about seizures and fits, or specifically epilepsy. Yeah. So if you've just joined us, just go along. If you have any questions for Doctor, please put them in the chat. And if for any reason we are not able to respond to your questions, we will respond to them later. If you have any questions after this program, please send it to business and experts forum at gmail.com. Business and experts forum at gmail.com. And we will endeavor to respond to your question as much as we can. Okay, so there's another question here that says that um, what causes seizures in sleep, and how can it be best managed?
Yeah. So seizures in sleep. We know sleep itself. If for somebody who has epilepsy, um, there are various aspects of sleep, either the sleep itself or the sleep deprivation that can trigger the epilepsy, trigger the seizures, depending again on the type of epilepsy you have. For some people, it could be genetic.
Okay.
So they have the type of epilepsy that happens in sleep. I was telling you, so some of these frontal lobe seizures, they may have a genetic component. It's not uncommon to have somebody with frontal lobe epilepsy where the seizures are always in sleep. And sometimes that in itself gives the doctor, it's a clue that, this patient probably has frontal lobe seizures. So sometimes the genetics, it's sometimes the epilepsy syndrome. And, I don't think we fully understand. And sometimes you have to think, is it actually seizures? We see patients who be having, so we like to call them episodes. They're having
Right.
episodes in sleep. We don't know that they are seizures, because sometimes it's
Right.
a sleep disorder. There are some sleep disorders that can mimic seizures. So that's another big part of our work. So we do sleep disorders. So sometimes patients just wake up, punch their spouses, and it's a sleep disorder. So, and yet some epilepsies can look a little bit like that. So for me as a neurophysiologist, you tell me you're having episodes in sleep, I would like to be sure that they were seizures and then decide on what treatments you need to have. So, as I said, so maybe the type of epilepsy you have, it may be the genetic type. It may also be that actually you're having seizures during the day, but they are not being noticed. So there's so many possible scenarios that I would want to talk to the person to tease out what is what. I wouldn't want to say, one specific thing. It may not be seizures at all, or there may be daytime seizures as well, but they are being missed.
Okay, so the questions is coming into the chat, and I'm also conscious of the time. We've only got about 5 minutes to end this program. This program is very brief. I just want to talk a little bit about something that seems to be happening now, and which is a lot of us are working from home, and the effect of working from home on the spinal cord. Can you explain what you have observed in your work regarding the effect of the working from home on spinal cords?
So the spinal cord itself, not necessarily. So as I said, these oops, the terms, we have to be very careful the terms we use. So
Okay.
the spinal cord is actually the nervous tissue within the spine.
Right.
So, I'm not aware of anything specifically we are doing at home which might affect it. But, I think, well, the whole working from home thing is really worked so well for some people. It's given them a lot of flexibility. They can do more exercise. They are less sedentary. It's been the opposite for others. Others have found they are more sedentary. They're sitting. And I think, we've got to try and move around. But specifically in terms of neurology, what's some of the things we have seen? So not so much on the spine, yeah. So if you're sitting a lot, the posture is not good, you can get a lot of pain. Those are usually muscular pain, not necessarily impacting on the nerves themselves. But as we see some patients with a trapped nerve, there are nerves that are very close to. Actually, my elbow. There's a what we've seen quite a bit of. There's a nerve that runs very close to the inner side of your elbow. It's called the ulnar nerve, and especially usually it's the non-dominant side. So you see
Right.
the patient has been at home, probably not in an ergonomic setup. So you haven't had the right chair, you haven't had the right
Right.
table. So the right arm, the dominant hand is moving the mouse,
Right.
and then the non-dominant elbow is on the either
Stationary.
on the arm of the chair they're sitting
Stationary.
on or on
Yes.
the table, and they're putting direct pressure on the nerve. So we
Right.
have seen a lot of, not a lot, I shouldn't exaggerate. We've seen quite a few more than we would normally see of ulnar nerve problems. The other thing we've seen a bit more of is problems with the peroneal nerve. I can't show you my legs, of course, but this nerve runs on the side of the knee.
Right.
And again, it's very close, it's under the skin. You put pressure on the side of your knee, you could easily, especially those who are a little, have less fat, you could be putting pressure directly on the nerve. And then if that is severe, you could have a foot drop where you can't, some people call it a drop foot, depending on which part of the world you're in, where you have difficulty lifting your foot up at the ankle. So when you walk, it flops. So you could have, we've seen a few of those as well. But I think the main thing from working from home, and not just in neurology, but what we are all worried about, and I know for some people it's been the opposite. Somebody said, look, working from home, I went to my parents in the rural part of the country. I've been doing more walks. I don't have to do that horrible commute on the train. So I've been using myself. So some people, it's actually increased their physical activity. But
Right.
on the other hand, some people have, become more sedentary. And I think it's a sedentary thing that worries, it should worry all of us the most. We just need to get moving. Whether we are working in the office or working from home, we have to figure out a way to increase that activity. I mean, that is what is really, really, right now, the ONS data for the UK recently came out, and COVID, the list of causes of death, I think COVID was about 24th on the
Oh,
list.
jeez.
The things and the normal things are coming back. The ischemic heart disease, high blood pressure, strokes, and all those things, diabetes, impacted by physical activity. So I think physical, yes. So you could have problems with the spine, and problems with the nerves. But I think the big thing everybody worries about is the sedentary or lack of physical activity for some people, and also the social isolation. I think some people has been good. I mean, I didn't have to work from home, but even when I was at home for a bit because I was in quarantine or isolation or whatever, I've always had my family around me. It's been easy to
Right.
be socially engaged. But I know some young people, people from Europe who were living in a bed sit. This thing happened and they couldn't go home. They were here. I mean, it's really, really, those little chats we have in the on the corridor with a colleague or in the loo, we both go to wash our hands and say, oh, hi, how's this? All this was helping us. And I think for some people it has been a big struggle.
I
So I
see.
think working from home, great for some people, terrible for others. But I think the main thing is to know the risks and
Okay.
take steps to minimize those risks for yourself.
Okay. Okay. So we've just got. I mean, we're actually out of time now, but I've got one question that I think we need to
Okay.
ask. So one of the ways of detecting activity in the brain is through an MRI scan. Okay. Now,
Activity. Yeah. Okay.
yeah, activity in the brain is to use an
Mm.
MRI scan. But we do know that there are some people who are what we call claustrophobic and just cannot settle down in the MRI scanner.
Yes.
What alternatives are there for such people when they definitely need a scan to determine whether there's any activity in the brain?
Yeah. Yeah. So, I mean, MRI scan, I know what you mean by activity. So the general MRI scan, so it's looking at the structure. So I wouldn't use activity, and
Okay.
I'll say it's looking at structural things. There
You
are
see,
types of
I'm not a doctor. I'm an accountant.
I know, but I know there are some doctors on there. They're going to accost me if I don't say some of these things.
Okay.
But so I think MRI, at least the standard MRI, it looks more
Yeah.
at structure, and the neurophysiology looks at function. So
Right.
structure and function. So yeah, but your main question. So again, these are things I think you go back to. I mean, that is a thing. I think whatever it is, we go back to the person who's referred you. I
Right.
couldn't have the MRI. I did try, but I was claustrophobic. I had a panic attack. Okay. And there are options. There are MRIs. There are what we call open MRIs. There are not many of them around. At least not in the UK. I know there are some of you from other countries who might have more of them. But there are options. So with everything, I think we need to be empowered. We don't just sit on our issues. The doctor referred me to an MRI scan. I couldn't have it because I was claustrophobic. The story hasn't ended. My problem is still there. I go back to the referring clinician. What are my options? And you'd be
Right.
surprised how often there are options. But if you don't ask,
Okay.
nobody offers. Everybody assumes, well, you're okay. So
Right.
just whatever it is, it's your medication, it's whatever it is, go back. Let's be empowered. Let's go back to, and also your doctors are on your side. They do want to help you. And they all want to go home knowing that they've solved a patient's problem. So please don't
Okay.
just sit and grumble about your symptoms. If something
Okay.
has effect, go
Okay.
back.
Quick thing. Can you have an MRI scan under sedation?
Yeah,
Okay, so you could request for sedation then. I mean, I struggle with MRI scan. That loop to go into it. So could that be
yeah.
the sedation?
Yeah, I hesitate to say request because you go and tell your doctor I'm requesting. So that you have to approach that conversation, uh, carefully. If you go out, you can't go and certainly can't go and demand it. Just go and say what your problem is. I could not tolerate the MRI. What are my options?
Okay.
MRI and the sedation is possible. MRI and the GA, of course, we do that, and we do that a lot. As you can imagine, in children, we do a lot of MRI and the GA. But you always have to think, well, I'm giving this person a general anesthetic, which has
Okay.
its risk. Does the risk really justify the benefit? So I wouldn't go and demand it from your referring clinician, but have a chat about what are my options. I could not have the MRI in the standard way. Is there anything else that I can have?
That is really really useful. You know, we've more or less come to the end of the program, but I just want to recap some of the key points that you have made, and I think it's very important that we recap the key points. The GA you just mentioned is general anesthetic. So the
General
people who
anesthetic,
know
yeah.
general anesthetic is GA. Now you talked about the fact that a seizure is not always an epilepsy, which is very important. Sometimes seizures can be mimicked, to
Yeah.
use your term. And you've also said that there are different types of seizures, and it can be
Hmm.
intense or almost sometimes unnoticeable.
Yeah.
Okay, and it's always useful, especially when you are a parent, to record the episode or a seizure when you have a child who is going through an episode. It's very important. Then you also said that tests are carried out, and the aim is to capture the episodes. So you can carry out tests to capture those episodes, and it could be sometimes within 30 minutes or sometimes a bit more, and can help with medication as well. The diagnosis is very important. There are risk factors for epilepsy. Some example: any brain damage, head injury, stroke, and recent dementia. And then he also said something about the fact that epilepsy can affect all communities. There's no one community that is mostly affected by epilepsy. It can affect all communities, and it's important for a patient to have as normal life as possible, especially if it's a young person. You don't want to kind of limit them and say you cannot go out there because you've got epilepsy. So it's really important. And when it comes to medication, you said don't be afraid to let your doctor know if you can't tolerate some medication. Really important. And I'm pretty sure that I'm hoping that our audience out there are taking note of some of these key points because these are really important. It has been really, really insightful for me, and I'm sure it's been really insightful for the audience out there. As I said before, as I said during the program, if you have any more questions, please send those questions to business and experts forum at gmail.com. It's going to come on the screen shortly. So you can just email your questions and I will forward those questions to Abner, and then we will respond to you, definitely respond to you. Um, and also, before we finally wrap up, I just want to introduce our next guest on the program, who is going to be Mrs. Um, Ibukum Olajide. She is a business entrepreneur. She's appearing on the program on the 23rd, on the 13th of September, which is 2 weeks from today. She's a CEO of Chili Gold, and that's a unique business which transformed chili, as we know it, or pepper, into a variety of products for a wide range of markets. And she's also known for providing motivation for prospective entrepreneurs by helping them transform their passion into business profits. And she'll be sharing her story on just being an outlier because she is pursuing a pathway that is different from everybody else. She's making a difference by being different. She's kind of shaking the status quo. So please join us on the 13th of September, and then we'll have a chat and just to learn a little bit more on the story about Mrs. Ibukum Olajide. Right. Okay. So, I mean, one thing we do on this program is that we don't let our guests go without putting them on the spot.
I'm
So
dreading this, by the way.
you were dreading it. Oh,
I'm
don't dread
dreading
it.
it.
Okay. So we are going to make it very, very easy for you because you've been so helpful. Okay. So we're going to ask you to stretch your arm and pick anything you can find in your home, in your house. Anything you can find. Just pick something. What is that?
A pen.
Good. Okay. So what you're going to do for us is that you're going to pitch to us and convince us to buy that pen for £200. So that is your task today. See, look at the pen and pitch to us and make us buy that pen for £200. Starting from now. You've got 30 seconds starting from now.
Actually, I was right to dread this, but seriously, this pet was actually. I'm not sure I'd actually want to sell it because it's in memory of a dear friend's father who died in 2016.
I
So
mean,
this
as
pen
old as
was
a pen.
very, very precious. So even £200, I wouldn't give it to you, Marcus. Sorry,
So you're not going to sell the pen.
I wouldn't sell this pen.
Okay,
No.
if you're not going to sell the pen, you have to find something to sell then.
Oh dear. Um.
Right, sell
What?
us
You
the
can,
brain. Sell
oh
us,
my
sell us, sell us
God.
the brain. Sell us the
You
brain,
can.
the prop.
You want a brain?
Yes. Or sell
I
us.
no, I don't know. I don't want to sell the brain either because my students and my trainees really love it. I'm sorry. I'm not very good at marketing. I could have
You
told you that
see,
right from the
you see,
outset.
you know what I'm going to say to you? Just stick to your profession, Abner, because
I
you'll be
will.
a very
Thank you.
bad
Yeah. Yeah.
salesperson.
Yeah.
Anyway, it's been a pleasure having you, and we just want to say thank you very much. Thank you very much for coming to talk to us today.
Can I say thank you, Marcus, for organizing this as well? I've attended a few of the sessions and they are indeed very, very helpful. Thank you for all you've done during this lockdown. You've helped us to stretch, to exercise, and lots of things. So thank you very much. We appreciate your vision and the energy you have in getting us together. So thank you too.
I do what I can. I just like to give back to the community in whichever way that I can. So thank you also for appreciating it. But as I said, this program is free. It's for sharing knowledge. So please tell your family, tell your friends, your colleagues, let them sign on, listen, get yourself a notepad, write down some of the points, It's just knowledge we are sharing, and it's all free. It is not for sale. So until next week, sorry, at least I say next week. On 2 weeks, in 2 weeks' time, that is on the 13th of September, when we will come your way again. Please remember to subscribe to this channel and also click on the bell when you subscribe. And I've been asked the question about how you subscribe. When you click onto the link that I sent out, you see the word subscribe there. Click on that subscription sign and click on the bell. The reason why you click on the bell is because when we have a next episode and we schedule it, you'll get notification straight away. So please subscribe, get your family and friends to subscribe to the channel, click on the bell so you get notification. And remember, if you have any other questions for Abner, please put them on business and experts forum at gmail.com, and we're never to respond to all those questions. And as I say every time, every episode, I say it has been great having you out there as the audience. Without you, this program will not take. So until the 13th of September, when we come your way again with Mrs. Olajide, please keep logged on to Business and Experts Forum and see you on the 13th. Bye for now.